So without any further ado, let me hand over to Angus, who's going to start us off.
Thank you, Rachel. It's a real pleasure to be here from early morning in Princeton. And it's one of the silver linings, I guess, of this epidemic, that we get a chance to talk about this thing and share some of the things that some of us have been trying to think about. Let me bring up my screen. Not sure what to do here. Can you see that? It worked before. Sorry, I appear to be stuck. There, okay.
Yeah, that works.
I think you can see it now. Thank you very much, and I'm sorry for the technical glitch. So, like Richard, I'm going to talk about inequalities in the COVID-19 crisis. And yeah, okay, find out which buttons still work. So I wanted to start with some quotations, which are just to suggest that this relationship between inequalities and pandemics is being very deeply embedded in thinking for at least 150 years. Rudolf Virchow was a German physician who is famous for really understanding cells, how cells work in the body for the first time, but he's also the father of social epidemiology. And here is one of his quotes, which is that medical statistics will be our standard of measurement. We will weigh life for life and see where the dead lie thicker among the workers or among the privileged. The second quote is more recent, from Paul Farmer, one of the founders of Partners for Health and famous for his work on HIV/AIDS. And he says, inequalities have powerfully sculpted not only the distribution of infectious diseases, but also the course of the health outcomes among the afflicted. Walter Scheidel, the classicist and historian at Stanford, in his book, The Great Leveler, 4 different kinds of violent ruptures have flattened inequality: mass mobilization warfare, transformative resolution, state failure, and lethal pandemics. And he pretty much suggests that those are the only things that can really flatten extreme inequality. And then much more recently, from CBS 60 Minutes the other night, a situation like this, it highlights problems that already exist in society that people haven't noticed. Suddenly you see things, it's like an X-ray machine exposing societal faults. Now, just a warning, I think from now on, I'm going to put this on all my papers and presentations, that all these calculations are subject to revision. The numbers are changing on a day-to-day basis, and I may have gotten something wrong. When you're trying to recompute these things every day, bad things happen. I wanted to start with something that's easy to forget, but there's a huge central inequality here between the people who die and the people who live. And people will often say it's so unfair that he died or she died. And so that inequality is pretty important in this situation. So if we look at the groups, obviously the old are dying more than the young. Men are dying more than women. The sick more than the healthy. Pre-existing conditions, particularly obesity, diabetes, and heart disease, make you more likely to die of this. The additional risk is close to proportional to pre-existing risk. So it's like you had a risk coming into this epidemic, and then there's an additional risk, and that additional risk is sort of proportional to the baseline risk. So you could think of that as being sort of fair, right? The inequalities that were there before are just magnified a little bit. And if so, you can think of this as just bringing death forward with maybe modest effects on life expectancy, at least over a few years. But there's another attitude to this, which is that these inequalities were unfair in the first place. I've heard people argue, I'm not sure I would argue it, that it's unjust that men die earlier than women. and COVID is making that inequality worse. I think there'd be much wider agreement that if disabilities penalize people, then that makes it even worse. Disability is punished even more. I wanted to also think about the familiar income and wealth inequality. You know, it's possible for the rich to hoard all the wealth or all the income. So you can imagine a society in which the rich have everything, and you can also imagine one where the poor die of hunger while the rich are well-fed and living in their castles, or other diseases. This infectious disease are different here, partly because the rich cannot really isolate themselves forever. It's not impossible. You can climb into your castle or put a gate around your city, wall around your city, though once the virus gets in, you're toast. Cities have historically segregated by race to avoid disease, and much horrors have happened in that name. But societies and countries today are very interconnected, so it makes it very hard to avoid infection. So you can't really be a rich person without the infection and a poor person with it. So this cuts across vaccine versus drugs. The key thing about a vaccine here is if it's going to work, it needs to cover basically everyone to be effective. That means not just within the countries, but across countries. Whereas a drug, on the other hand, if it was really effective, the rich could have this very expensive drug and prevent them from getting sick while the poor suffer. You could imagine that happening. So there's a distinction, as is often the case, between vaccine and drugs. There's a theory in social epidemiology called the fundamental causes theory of health inequality. And let me lay that out quickly. In the initial stages of a disease, it can affect sort of anyone, rich, poor, or both, geography, whatever. It depends on where it came from, how it came, the nature of the disease. Now for COVID-19, it seems like in the first days, global elites and traders were the ones who were most affected. That's been true for many earlier plagues, including the Black Death, not for cholera, incidentally. Cigarette smoking used to be more common among elites because it cost more, and doctors were more likely to die of lung cancer than patients, but no one really knew why. In England, for about 400 years, and that's simply because we couldn't go back earlier than that, aristocrats and commoners had pretty much the same life expectancy in spite of successive waves of disease, smallpox, plague, and so on. So what fundamental cause theory says is that inequalities open up only when the means to control exists, so that wealth and power can be used, otherwise not. If no one's known what's causing the disease, it doesn't help to be very smart or wealthy or powerful. But when a cure comes into sight, often the rich, better educated, higher social economic status can use it better. Now for smallpox, that took centuries. For COVID-19, it was almost immediate. We knew what it was. We knew why it was killing people, even in contrast to 1918-19, where people didn't know what it is they were dying of. This makes a very, very important point. It's the social distancing or other remedies that cause the inequality. It's not the virus that makes inequality, it's behavior and social structures, not biology. So it's these pre-existing social structures, the pre-existing inequalities, the structure of society that determines who lives and who dies. It's a very important point. I want to talk a little about education and death in the US today. So Ann Case and I have just published a book called Deaths of Despair and the Future of Capitalism. And I want to just mention how that feeds into this. So what we call deaths of despair, which are suicides, overdoses, and alcoholic liver disease, have risen rapidly in the US for those without a BA. This is educationally structured since 1995. Almost exclusively has the rise been among those without a BA. There were 158,000 deaths of despair in 2018. Of course, there's some people kill themselves or overdose in a normal year. So it's maybe about 100,000 excess deaths per year over normal. So the COVID-19 projections for the United States today are around 70,000, maybe a little more than that. It's been a little less, now going up. Some of those people would have died fairly soon anyway, so mortality in 2021 could be reduced, though there may, of course, be a second wave. But if you look at deaths of despair, there's been 100,000 deaths of despair a year for as far as we can see into the future. In 2018, overdoses fell a little bit, though we don't know what COVID is doing to people with addictions. Suicides are rising and likely to increase because of isolation. And again, let me make this basic point, these excess deaths are almost entirely among those without a 4-year college degree. They're socially structured. So social distancing further widens the gap between those with and without a BA. So just think of the fork here. Without a BA, you're more likely to be a manual worker. You're either essential or non-essential. The essential people risk their lives: health personnel, bus or subway drivers, elderly care attendants, food retail, delivery. The latter, the non-essential ones, lose their livelihoods or risk their livelihoods. These are people in non-food retail services, restaurants, etc. So you got this fork. I mean, you either lose your life or risk losing your life or risk losing your income. Now, Chai-Wei Chu and Rob Joyce at IFS have documented this for the UK, and I haven't done that here yet, but it's almost certainly very similar here as to the occupational, the sex, the age split of those people. But once again, it's education that puts you into that class, or lack of it. The US is now talking about opening up, and some states are doing so already. If your employer opens up and you decide not to come to work because you're scared and you think you're going to die, you lose your unemployment benefits. So you now have, for each individual, the choice between their money or their life, as it will. The educated elite stay at home, go on working, they stay safe and get paid, and they give webinars like we're doing right now. So if you think about this in terms of traditional inequalities, this will almost certainly widen the earnings premium for BA, which is currently at 80% in the US, as well as widening the mortality differentials between those without a BA and BA, which are widening already. Just as a second point, and I think you're going to hear about this in a week or so, that electronic learning doesn't seem to work so well for kids of less educated parents. So this is opening up educational divides which will be with us for many years. I wanted to talk a little about political inequalities and death, which I find very striking. In the US, we have 50 states, 25 of them have a Republican governor and 25 of them have a Democratic governor. As of April the 27th, which is 3 days ago, there were 10,368 deaths in red states and 39,679 deaths in blue states. So if you live in a democratically controlled state, you're almost 4 times as likely to die as if you live in a red state. Now, no one's claiming that you die because you're a Democrat, but it has all sorts of political consequences. So let me start with some Lorenz curves, which are very familiar to everyone. This Senate power living is a terrible label here. But along the bottom, you've got the cumulative percentage of population. And on the y-axis, you have the fraction of the Senate votes that are controlled by that fraction of the population. And because the Senate has 2 members for every state, the least populated states do much better than the well-populated states. So in fact, New York, California, Florida, and New York, Texas, California, and Florida have about 1/3 of the US population between them, but they only have 8% of the votes in the Senate. So that's what you're looking at here, a lot of inequality associated with political representation. And that matters right now. So if instead of looking at the people who are alive, let's look at the people who are dead and look at the Lorenz curve for them, it's even more extreme. So this is the Lorenz curve for the Senate power dead. So you've got about 5% of votes for about 60% of the people who've died. The House is a little bit better because it's selected proportional to population, and it's much closer to the green line. So if you like Gini coefficients, the Gini for the Senate votes of the living is 0.75, which would typically be regarded as an extraordinarily high Gini. The Gini for Senate votes among the dead is 0.88, and House votes among the dead is 0.78. And that's because the deaths are concentrated in a few places, particularly about 50 miles north of here, now spilling over into New Jersey, which has more deaths now than New York for the last couple of days. Well, why does this matter? It matters because we now got to a point where the rhetoric in the Senate is no more bailouts for blue states. We're not going to give any more money to these blue states. And it's like, okay, no more bailouts for people who died. So the lack of empathy across political lines appears to actually extend to the COVID deaths themselves. What's more is the relief bills, as usual, have large corporate tax cuts. The lobbyists are not at all cowed by the presence of an epidemic that's killing large numbers of people. If it spreads, and that's the huge question, is this in the end going to infect 3/4 of the American population, as some epidemiologists think? Then it may be that once it gets to the Republican strongholds, then it'll be really bad. The people who live there, the Trump voters, the Republicans, they're older, they're more likely to be male. There's worse health care in those areas where they live. And if the virus spreads widely, all these political calculations will change, and you will see the Senate becoming much more sympathetic towards these people. Just to give you an example, where I'm sitting in New Jersey reported 320 COVID deaths yesterday. In Montana, where we like to spend the summer and where we hope to spend August, there were 0 deaths yesterday. That doesn't mean there's no COVID in Montana, it's there, but the number of deaths varies. Let me say something about racial and ethnic inequalities, which I know has been an issue in Britain too. There are higher COVID-19 mortality rates among Blacks and Hispanics. The proportional theory doesn't really work here because the baseline mortality rates for Blacks are higher than for whites, which is consistent, but the baseline mortality rates for Hispanic is lower than for whites, which is not consistent. Now, I'll show you a slide in a minute, but the CDC, the Center for Disease Control, argues that COVID-19 inequalities are largely spatial, which is just what I've been talking about in the political context, and that many whites live in areas without COVID-19. So, Montana is full of white people. There's very few or no COVID-19 deaths there. And so that's why the whites do better than the Blacks. And New York City's, where most of the deaths have been, has a racial ethnic composition that's very different from America as a whole. Housing and density are likely to be important, as well as occupation and the things I talked about already about working in healthcare. Native Americans appear to have been very badly hit. So we don't really have good data on this, but there's very convincing stories about the Navajo with very crowded living conditions and often no running water, so you can't even wash hands. Here's the numbers. So the percentage of COVID, this is as of April 22nd, the percentage of COVID deaths, 52% non-Hispanic whites, 21% non-Hispanic Blacks, and 16.5% Hispanics. The percentage of population of these 3 groups you can see in the next slide, and you can see that the percentage of white deaths is below its population percentage, and the percentage of Black deaths is close to double that of its population percentage. And there's been a lot of agonizing and talk about this. The CDC, though, these are not my calculations, these are the CDC's calculations. What they did was they went through county by county in the US and reweighted the population so that each county got a weight depending on how many COVID deaths have been there. So if there's no COVID deaths there, that county doesn't count. And when you reweight that way, you can see that whites are actually doing worse than Blacks. There's 52.1 versus 40, 21.2 versus 18. So what that tells you is not that bad things are not happening to African Americans. What it tells you is that this is a largely spatial phenomenon. And it probably does say that hospitals are not treating Blacks worse than whites. It seems to rule that out, but what it doesn't rule out is segregation and density and poor housing conditions, which have always been an issue. Let me finish by talking about very speculative things about the long run. where there are many, many forces and we can all wave our hands around. It's possible that globalization will slow. It's already been slowing, slow some more. It might possible that some reshoring of jobs as globalization shows further, but there's always automation, which has actually been much more important for working people anyway. There's I'd say a large permanent move. Obviously, it's going to be less than what we see right now, but it's hard to believe that e-commerce, e-communication, e-socializing, e-meetings, and so on will not go ahead and not go back to the level of before. I was at the National Academy of Sciences meeting over the weekend. Everybody over and over and over again said this was the best ever meeting. There were more people there. The voting was much more credible. All sorts of problems they worried about not getting people to come to meetings were solved overnight by using Zoom. All of this favors the more educated and points to more automation, because the people who are going to be making these things think life is going to be wonderful. US healthcare is likely to change. Maybe not if it comes out of this crisis as having seen it perform really well, the hero scenario. It will change if it's seen as a villain. And it's already being changed. New Jersey has decided that foreign doctors can work here. New York has consolidated its hospitals. The cost of healthcare, which is astronomical in the US, twice as much as anywhere else in the world, essentially works like a poll tax taking a wrecking ball to low-wage labor markets. And that has been one of the big forces making life worse for people without a BA in the US, and we can hope that that might change. Final slide. I'm hoping that some of the institutions that support equality in the face of risk might actually be enhanced by this pandemic. So there might be a greater recognition that public institutions are required to manage risk, that markets and globalization have high returns, but high risk. You can turn everything over to the market, but then when things fall apart, you're in a mess. Now in the United States, a huge amount of our social safety net is actually privately provided through firms, much more so than in any other rich country. That turns out when the firms close or this pandemic, it's a terrible idea. So we need to be adjusting our social portfolio away from risk and towards accepting lower income. Also, a greater recognition in the United States, this has always been a terrible thing, it's gotten worse in recent years, that public goods are really important. People, especially people on the right, think that public goods are just rich people paying for poor people, lazy people to get things that they're not entitled to. And we should realize these public goods are important in an emergency. There's probably some restoration of social capital. I mean, you've seen that in Britain. Bob Putnam has written a new book in which he talks about we versus I, and we may get more of a restoration of we instead of I. This Queen's speech a week or two ago invoking World War II, that wonderfully moving thing when she said, the first time I talked to you 80 years ago, I was with you then and I'm with you now. That construction of social capital seems to me very likely. It's not so likely here, given our leadership. There might be some restoration of trust in science, which has been under great attack in America. Tony Fauci, the 79-year-old, hitherto fairly obscure National Institutes of Health official, is now the most trusted man in America. But just a note, caution, beware of the tyranny of experts. The experts always need to be democratically challenged. And there's a very interesting dichotomy here between the US at one pole, where the doctors speak but are only occasionally listened to, and Sweden at the other side, where their institutions are set up so that the politics cannot interfere with the chief public health officer, who's taken a line which is very different from what is happening in other countries, and where it might succeed, but it's much too early to tell. But right now, the deaths in Sweden look really bad. So I will stop there. Thank you very much.